Are you recruiting in the focus for?
So welcome back. We're going to resume the program, and Martin is, Dr. Falk will provide us the overview of the phase 2 data leading now to.
Oh, yeah. Okay.
Yeah, don't relax too much. You're back up. Microphone. You have it already.
Portfolio of a similar size.
Yeah,
that's right. Come on, man, stop it.
So I think
Are they?
giving you next slides or so on the quick overview It's not necessary here. Okay, let's continue. So, to further broaden the basis of what we're talking about today is I'll give you the highlights from the pancreatic cancer phase 2 trial with TH302. Based on the initial phase 1 data, where I've shown you just one or two slides upon, that was followed by a phase 1b trial, where TH302 was explored in combination with gemcitabine, docetaxel, and pemetrexed. And the MTD in combination with TH302 was, in combination with gemcitabine, was determined to be 340 milligram. However, with a 240 milligram per square meter dose, was also some observation of potential activity, and that was the reason why in the that's the trial here. Yeah, that's what I just said. Why in the subsequent phase 2 trial in pancreatic cancer, 2 doses of TH302 were explored in combination with gemcitabine, and there was a control arm of gemcitabine only. Roughly 70 patients per group, open trial design, and prospectively randomized. Primary endpoint was progression-free survival, and the other endpoints, of course, survival, CA99 response rate, were also measured. Of note, in this trial, crossover of these patients here after a disease progression into combination treatment was not only allowed, but it was somehow promoted. So there was significant crossover from gemcitabine arm into the combination treatment after disease progression. Target group was the same as, practically the same as now in the Maestro trial. So locally advanced and metastatic patients, first line. And the treatment schedule was, of course, also the same, day 1, 8, and 15 of a 4-week cycle, and efficacy and safety assessments every 2 cycles. And that's the primary outcome, the progression-free survival by treatment arm. So the black curve here is the gemcitabine mono control arm with a median PFS of 3.6 months. And the green is the 250, so the lower dose, and the red curve is the 340, so the higher dose of TH302 with median PFS of 5.6 and 6.0 months here, which was significant for the higher dose, for the 340 dose. What is a bit reassuring here for me in this slide is that in practically all situations, the 240 milligram dose was slightly lower than the 340 milligram dose. What about subgroups? How robust are the results here? So this is the primary endpoint split down by important prognostic parameters, and roughly summarizing, my interpretation is that none of the parameters here is grossly peaking out either to the left or to the right. For example, there's not any median of the subgroup analysis above the 1.0 hazard ratio. So I think this is also quite consistent with the assumption that there's a real effect behind the observations. What about overall survival or first response rate? Quick look here. So gemcitabine alone, no CRs, 10% PRs. With the higher dose of TH302 added, this goes up to 26% responses here. This was significant here compared to gemcitabine alone. So this is also the better PFS is also reflected in an increase in the responses here. Survival, I mentioned that, is probably confounded by significant crossover. These are the numbers here. Black again is gemcitabine alone. Median overall survival is 6.9 months. The hazard ratios are not remarkable here compared to the medium or high dose of TH302 because of the low sample size. But the medians here are 8.7 and 9.2 months median overall survival with the higher dose of TH302, which is the one that is currently being used in the Maestro trial. So that is basically the efficacy outcome. How do these results now compare with the milestone phase 3 trials from FOLFIRINOX and from nab-paclitaxel, so the Prodigy and the Impact trial? Nora has, Dr. Shiu has already talked about the response rates. Quickly looking at the survival, the median overall survival data. So in the gemcitabine control arms of the large phase 3 trials, interestingly, this was very consistent with 6.7 or 6.8 months median overall survival. Also PFS here was quite consistent. And the prolongation of the median overall survival with FOLFIRINOX to 11.1 or with nab-paclitaxel to 8.5 months here, so roughly 2 months improvement. In the phase 2 TH302 trial, the gemcitabine monoarm was very identical to these numbers here, and the median also here compares favorable with the results of adding gemcitabine or using FOLFIRINOX here. That gives us some confidence that TH302 indeed may really reach efficacy readouts that are absolutely comparable to these compounds here, and that was very much driving the decision to move forwards into a phase 3 trial. Safety, we haven't commented much on that so far. Again, Dr. Shiu has commented on that. This is again here a comparison of FOLFIRINOX, the combination of nab-paclitaxel and gemcitabine mono here and here, or the phase 2 TH302 plus gemcitabine trial. So when looking for gemcitabine, for neutropenia, that is substantially increased here in the 2 phase 3 trials. Is also significantly, approximately the same range here seen when a TH302 is added. Thrombocytopenia is even being increased more here when TH302 is being added to GEM. However, these were all manageable, and there were no clinical issues associated with these higher frequency of grade 3 or 4 thrombocytopenias in the phase 2 trial. Febrile neutropenias are increased by either addition of nab-paclitaxel or use of FOLFIRINOX compared to gemcitabine alone. This is also being seen with TH302. Fatigue, which seems to be a bigger issue, especially with FOLFIRINOX, but also here with nab-paclitaxel, is practically not influenced here in the TH302 trial. Neuropathy, we've briefly talked about that. It's also increased both with either FOLFIRINOX or with nab-paclitaxel. That's not an issue with TH302. Diarrhea, also not an issue. Maybe some issue here in the FOLFIRINOX regimen. And there is this relatively characteristic of rash in Th302, which can be addressed by specific skincare measures that we have been implementing into the Maestro trial.
So as I look at this, let's say if we look into the future and this were to be a positive phase 3 trial, you're definitely going to have a differentiation point around fatigue and neuropathy between FOLFIRINOX and nab-paclitaxel. How much, for those of you who have experience with the Maestro trial, knowing that it's blinded, are you seeing thrombocytopenia? I mean, that stands out to me, but we rarely hear it. I mean, this is what, our 7th workshop, we rarely hear it being a clinical issue. So I'd be interested to know, I mean, are you seeing thrombocytopenia in the trial that you're treating, or what has been your experience? Maybe Karen, you can answer, and Radmila, maybe you can as well.
So I've got, I think I've got 5 patients in now, and there's like only one that is still on medication, the one that I think has the investigational product, has the big cyst, and he has the thrombopenia as well. Yeah,
He's having. And how are you treating it?
Thrombocytopenia.
Yeah.
You have
But
no
it's,
other
it's
patients?
manageable. It's manageable. I mean, there's no bleedings. It's only.
No, he has no
Figures.
bleedings, but we do have to have, you have these strange dose reductions as well in this schedule, where you have to, look at every day separately and go up and by. He has a.
So he's dose reduced because of
He's
thrombocytopenia.
dose reduced, but he has had delays as well. Like I think.
What sort of degree of
it's coming back.
thrombocytopenia is it? What sort of degree? What's the platelet count? How much thrombocytopenia? Is it really? There's a platelet count coming back at
No.
below 50 or
Below 50, he's in between 40 and 50.
quite substantial. Then.
Not
Grade 3.
not below 40, but in between 40 and 50, and at several measurements, at several we challenge him and he comes back down, and it's
So what are you doing to manage it? You're dose reducing
We
platelets?
follow the booklet, which is
She answered it right. She answered correctly. We followed the booklet.
yeah, but that's the thing. I've got it all. It's on the wall in the ward because it's really.
You are the winner today.
Radmila, how about you?
I wouldn't say that we see more of the thrombocytopenia that we are used to, because it's quite common for gemcitabine. So, few patients had, but it was like grade 2. So, we just also handling according to the protocol.
Very good.
So you're not seeing toxicities above what you experience normally with your experience of using gemcitabine monotherapy?
No, only really the tiredness. That's an issue.
I have to say, this is my age, was in practice, gemcitabine had not been out yet, okay? Then it became available, and my initial experience with gemcitabine was awful, and I was in a practice with 6 other doctors. They were all having a wonderful time with the drug. Great, it's tolerated well, seems to work great. All of my patients had a horrible time with fatigue and blood count issues. And so, it really kind of taints your initial experience with the drug when it's new and you want to use it, and then the first 3 patients out of the chute really have a lot of issues with it. So when you say fatigue, I can understand, because my experience was a fatigue experience with patients.
But it's quite uncommon because it's really after the first cycle, and we are not really used to it. I've got good experience.
Interesting. Yeah. Good discussion.
What's the mechanism for thrombocytopenia?
So, in the monotherapy trials, there was no relevant bone marrow suppression toxicity observed. However, when Th302 is added to the standard cytotoxics, also observed with docetaxel or doxorubicin, it increases the bone marrow toxicity, and it just increases the characteristics of the combination partner. So doxorubicin, for example, has on very low thrombocytopenia is a prominent neutropenia, and that is being aggravated by combination with TH2. And here, exactly as you said, so for gemcitabine, the thrombocytopenia is much more prominent than the neutropenia, and that is being aggravated here in combination with TH2. So the assumption is twofold from a mechanistic point of view. The one is, it has been demonstrated that the bone marrow also does have significant hypoxic regions. And the other one is there is a very low amount of the active metabolite, the bromoisophosphorate mustard, being found in the circulation. Yeah? And it could be that cells that are especially sensitive may then, non-tumor cells, may then also be hit. Yeah.
So it's getting sequestered into bone marrow or bone. So the drug, TH302, you're saying it's concentrating within bone marrow, or?
That's what we don't know. We don't assume that this would be measurable. Yeah. But from a mechanistic point of view, since drug is hypoxia activated, there is some reports about the parts of the bone marrow being hypoxic.
The other thing, just a question for the group, I've heard now at least 2 different times that the neuropathy is different with nab-paclitaxel plus gemcitabine versus FOLFIRINOX. Can you describe that for us? What's the difference between the two? Sebastian,
I had a
maybe
patient describe it to me just yesterday.
Yeah.
So the patient described it thus, and he had FOLFIRINOX first up, and now he's on gemabraxane. He's private, so that's why he's having a second line.
He's private.
So that's why he's having a second line. Yeah.
It's a second line private.
Yeah. Anyway, he's doing bloody well actually. So, no, he described when he had the FOLFIRINOX, his hands and feet were numb, such that he couldn't feel them, and accelerating in the car and braking in the car was occasionally quite dangerous because he couldn't feel where the pedals were.
Nice to see you still driving.
Got better from that. And the paclitaxel neuropathy was like pins and needles, so he could still feel things, and it reverses slightly more quickly. But actually, whilst he's going through therapy, he's on it at the moment. He's still got a bit, but it was a different feeling. But I think the understanding is that the nab-paclitaxel is more reversible as well, and certainly I've seen lots of people. I treat colorectal cancer as well. Lots of people with sort of ongoing neuropathy secondary to oxalic
because of the oxalic. Yeah, interesting.
I think that oxaliplatin neurotoxicity also the patients are not supporting the cold water. They are complaining when they're washing their hands.
Sure.
This is very specific for oxaliplatin neurotoxicity, something which is absolutely not, you cannot observe that with nab-paclitaxel.
You know,
The duration, with nab-paclitaxel you have a reversible neurotoxicity after 21 to 28 days. You can decrease of 1 grade minimum or 2 grades. Then in patients which are experiencing grade 2, grade 3 neuropathy with abraxane after 21 to 28 days, usually are going back to grade 2 or grade 1.
Yeah.
It has been demonstrated in the phase 2 at the beginning.
So you stop therapy for 21 to 28
Yes,
days?
in fact this is a cycle, so it's quite well. Each time you are restarting the cycle, you are re-increasing the neuropathy, but in fact the patient are quite well when they are arriving for the treatment.
Is that a concern though for the patient that he's not getting or she's not getting therapy for 21 to 28 days?
Well, you wouldn't necessarily stop the therapy.
No.
It'll resolve, but you don't
Yeah.
necessarily stop.
Yeah, you don't stop the therapy because of that. No, it's different from oxali. Whereas oxali, if they're getting persistent neuropathy between cycles, then that's a signal you're getting to that cumulative point. Whereas, you know, they tell you 900 milligrams per meter squared as a total, but people are actually different, and you can treat people to more. Once you get the persistent neuropathy with oxali, you need to start stopping oxali. But you don't have to with the nab-paclitaxel. You can continue. The other thing is you do get a rash sometimes with paclitaxel. Different rash,
Okay.
but you do get a rash sometimes.
Well, it's not this is the grade 3-4
okay,
only,
yeah,
so
sorry,
it's not
yeah,
reported here.
Yeah, sorry, yeah. Fair enough.
To come back to the neurotoxicity,
Yeah.
in fact you have a completely different toxicity because one is related to the platinum compound. It's like heavy metals, okay, like lead, for example. And for nab-paclitaxel, in fact, it's because it's tubulin inhibitors. So you have the transmission of signal is modified because of the tubulin inhibition.
Right.
Okay, this is a major difference between the two neuropathies.
Yeah. Makes sense.
And that's why one is cumulative and the other is not.
Yeah. Very good.
Okay, I think this was
Yeah.
that was just a summary.
Is
And
there-
Question. Well done. One question.
Is there any reason why you have such unconventional dose modifying?
I'll try to address it in my presentation.
We have a whole section on it. Yes,
I'll
exactly.
try.
Specifically for you, Karen.
You may not like the answer.
That's why it's specifically for you.
Very good.
Other discussion points or comments anyone has? Because I think that most worthwhile part obviously is the sort of discussion we're able to have. And we will finish on time, so I know we're not planning to follow the agenda as closely as originally defined. That's part of the beauty of the format, is we can be interchangeable if we need to. This case, I think, is always very interesting because it brings up a lot of comments for discussion. So let's just discuss this one, which leads nicely then into Bruce's presentation that will follow. So this is a 57-year-old patient, ECOG of 1, has upper abdominal pain and some back pain, some weight loss. Earlier was diagnosed with type 2 diabetes. He is still working full-time. His primary physician evaluates him and he has some abnormal LFTs, a normal bilirubin. Ultrasound shows a mass in the head of the pancreas, no obvious metastases, no ascites. He has a spiral CT scan. He shows a mass in the head of the pancreas and vascular infiltration of the superior mesenteric artery, no distant mets, elevated CA19-9. So earlier we had some discussion on how patients present at the centers. And really a question here is, because of Maestro's eligibility criteria, who defines if a patient's resectable or not? And is there a clear definition at your sites of that categorization of patients, if a patient's not resectable? So Radmila, at your location, how has that worked out? Do you have dedicated pancreas surgeons at your location?
Yes, we do, and we have like oncology surgery team,
Yeah.
which is deciding for the patient, but usually infiltration of the big vessels is unresectable. So
Is this defined as any infiltration or a certain amount of infiltration or encasement or, you know?
if there is on the imaging, if there is infiltration of the vessel, then the
Any
surgeon
infiltration.
and yeah.
Okay. And if the patient, let's say, has, from a vascular infiltration standpoint, might still be considered for surgery, but has other performance status issues, is that a consideration for the surgeon as well? Like this patient is an ECOG of 1,
Yeah,
but
it's like a team, so we are also present. So we
everyone's
discuss it
making a
together.
decision
Yeah.
together. Yeah. How about in Francois, at your location? How does this
we
work?
still consider a possibility of a Whipple as the best palliation,
Yeah.
and I don't think we should exclude a possibility of resection there. It depends how circumferential the tumor is. I think 180 degrees is about the area where it seems infeasible. We usually will go in there and see if it's feasible.
So they'll have a exploratory laparotomy, or
Yeah.
I see. And do the surgeons ever tell you the patient's not resectable from the get-go? Please do, and we never are going to see the patient, or please try something and let's readdress the question.
You mean about downsizing?
Yeah.
Yes.
Yeah.
Not in our place. I think for if it's less than 180 degrees, I probably would suggest them and they will go in there. But if there's really a possibility of encasement, that could of course be another way of downsizing with site. It's the only thing we have available.
I see. Okay.
But usually we go there and
Yeah.
look for it.
Okay. So Geraldine, perhaps I can ask this last question here at your location. If the patient is, first of all, would your surgeons ever say this patient is not resectable?
Yes, I think it's a very interesting candidate for Maestro.
Is this a kind of patient that would be considered at your location for
yes.
Maestro?
Mhm.
And why, at this presentation, might this patient be a candidate? Would you think about the trial? Which is great, one of the things we want you to consider, but
Because for Ferinox, at the moment, it's only for first-line metastatic
Okay, so
patient.
patient doesn't meet that
Even
criteria.
if we try sometimes for Ferinox in locally advanced patients, but only if we think it will be there will be a surgery after that,
Yeah,
if there is a downside.
okay.
But no, that kind of patient is a very good candidate for Maestro.
Would you be thinking nab-paclitaxel gemcitabine as an option?
No, we don't use nab-paclitaxel
Not
at
in
the moment
locally
for
advanced
yes,
setting.
if there is no metastasis.
Okay,
Mm.
okay. So
Only for
really the
metastatic
definition of metastases present or absent. Yeah. Harvey, do you see locally advanced at your?
We do. I mean, assuming that the patient isn't resectable, and I think this is probably our clinicians would definitely consider this patient for a Maestro.
In this,
I mean, we work in conjunction with our regional team in Bristol, so these patients would be discussed at the regional MDT.
Okay.
That's the multidisciplinary team
Okay.
meeting in Bristol.
okay,
Whether there may be the potential for surgery.
yeah.
And assuming that that's not the case, then I think so, yeah.
Okay, so let's take the case a little further. His case is reviewed at a tumor conference. He's decided to have borderline resectable, i.e. try something. He receives FOLFIRINOX neoadjuvant chemotherapy followed by capecitabine radiotherapy with neoadjuvant intent, has some response, but within 5 weeks develops new lung metastases. So what options now do you consider for this patient? So he presented with locally advanced disease, now has chemotherapy and some radiation in a with a preoperative intent, didn't get to surgery but develops new lung mets.
He's definitely treating the UK by these guys.
Yeah. So
I would have done that. I would have given him FOLFIRINOX.
Yeah, I know, exactly.
Well, that's what
In France too. In France
no
too.
chemo
no chemo rats, okay.
I might
But
have
he
given
would
him
have gotten
chemo,
the
actually. He was still unresectable.
So
I
some
would have
part
given
of this
chemo rats.
story
Yeah.
is, okay, it's a possibility. Is this patient someone, or what would you do? Would you consider, since we're talking about Maestro, specifically eligibility for the trial? Would you think of some other type of therapeutic option? What do
I'd
you
need to go back and check the eligibility criteria, to be honest. Really, I would.
Yeah, say this one is not.
Is he eligible?
But previously untreated is mentioned there.
No, we can have
No, sometimes you can have treatment, but you have to
Is he allowed to
check.
have had I'd check this because
Right.
I want
Okay.
to give him gem.
Yeah.
Yeah.
So although you
But
can
is he
have
eligible?
treatment, you've got to have a gap.
You do.
I think 5 weeks is too short. I think it is literally 3 months.
I don't know.
This is
So
such a
they're
good
gonna-
segue to the.
I think I know that you're definitely allowed chemotherapy and you do not count the cap as a
40.
systemic dose. That's fine. But the issue there's a time window and that is too short. I can't remember.
So
It's too short.
we do want you, and it's a good segue actually to the next segment, which is the cases that we're discussing today. Certainly all of them could be considered for candidacy for Maestro based on presentation. Now most of the time you're seeing metastatic disease. This case is a locally advanced unresectable patient. Perhaps at that time could have been a candidate for Maestro. Now obviously has metastatic disease, and what does the preoperative therapy, where does that fit with the eligibility? And I think as we'll go through the eligibility criteria, we'll see that he actually still meets
Yeah, I
eligibility
can't see anything.
without
I'm just
a
going
need
through these.
for washout. So the washouts really follow gemcitabine-based treatment in the settings that you will use. So it is they are unique situations of patients that you may not be thinking of now that are eligible for the case, or perhaps patients eligible for the trial. There may be cases that are referred to you in. I don't know how many of you have local community doctors treating the patients in some other scenario, in adjuvant or something like that, and then they get referred to you for metastatic, or again a locally recurrent presentation, something of that nature. But
Actually, number 3 in the inclusion criteria, locally advanced unresectable or metastatic PDA, proven by histology, and previously untreated with chemotherapy or systemic therapy other than radiosensitizing 5FU or GEM, neoadjuvant or adjuvant. That would appear to exclude the FOLFIRINOX, which wasn't,
this was
unless you were calling it neoadjuvant.
chemo alone.
I agree
Yeah.
with you. I think this is not intended gap in the protocol, because the intention of the protocol is to allow all patients for whom gemcitabine mono would be an appropriate treatment. This would be for this patient. Yeah. But according to the strict protocol definitions, the protocol says a minimum
A washout.
interval of 6 months
Yes.
or so.
Yes.
So this is not fulfilled here.
Well, the Fulvera
Okay,
is not for that
clarification.
part
Yeah.
anyway, so the only question is if you had just given chemo-rad.
Yeah. But the other aspect too is the issue of preoperative therapy but doesn't get to surgery. That question has come up too. That we gave the patient with intent to have, with neoadjuvant therapy with intent to have surgery, but the patient never made it to surgery. Do I have to wait 6 months for that interval to pass? So that aspect also is not something that would be necessary, depending on the chemo that's given in the preoperative setting.
I mean, neoadjuvant as well.
The definition,
Definition
you mean?
of that.
Correct,
You
yes,
know, I
of
mean,
course. That is the key one. Yeah.
Unresectable disease, is
Yeah.
it neoadjuvant or is this conversion therapy? You know,
Correct, yeah.
it's, what are we talking about?
And
It's
defining
not, it's not an accepted
unresectable
standard of
disease.
care for pancreatic cancer, is
Yeah,
it? Neoadjuvant
yeah.
treatment.
No,
Obviously, in
in
Texas it
defining
is.
unresectable,
It is, the
Could
MD
be.
Anderson. They
Yeah,
got
MD
great,
Anderson.
great median survival on
Everything's
their
neoadjuvant disease.
yeah, well, you could say that, you know. Well, I gave therapy on Maestro, the patient actually responded well. You know, can I take them to surgery now?
Yeah.
I mean, that question has come up as well for
Well, you
patients
can for the
participating
patient, but
on
it's
the
a bust
study.
for your trial. I mean, it's a bust for that patient. You just, I mean,
Correct,
you
yeah.
kind of, I mean,
You know,
where
what's
we
right for the
have, Our
patient.
surgeons are very aggressive, so they never say never. They
Right.
will do angiograms. They will like SPAC5.
I mean,
type
for you,
radiology.
probably no patient is unresectable
No,
unless it's
but what they
metastatic.
would say is that please bring it back after having some kind of therapy, whether it's chemo-rad, whether it's chemo.
And
And
how
I think
long?
and then the only issue then is that it's only if the patient then says, you know, although you might say that I'm borderline, I don't actually want to go to a field whipple.
Yeah,
Then you can do Maestro, and even if they responded, and in fact the patient said, you know, I never wanted it anyway, I think that's fine. But I think if we had any kind of whisper from the surgeons that they were going to go in there with any kind of response on non-progression, I wouldn't want to put them on the Maestro because I think it would be good for your trial, because let's say they did respond and we had to do it for the best of the patient,
sure,
which is good for the patient but not great for the trial, because
right,
you want your numbers to be as pure as possible. Your
Correct.
patient
Correct.
to be as pure as possible.
yeah, yeah.
It's the issue between clinical practice and the clinical trial, clinical science.
Yeah. And what the protocol intends, and then how we all interpret, right, what that protocol is saying in terms of the patients that were
That's not I know.
selected.
I mean, when you talk to radiologists who, so we had a talk at that mass meeting by the SPAC radiologists, and they say it's a central review process. The problem is that surgeons hate radiologists in the sense that they say it's a joint, it's usually a surgically led MDT. I don't know whether it's like in your MDTs. Hepatobiliary MDTs, as far as I mean, are surgically led, even though only 8% of them are ever approved from the start. But the surgeons always want to say, you know, I can get whatever out, and
Sure.
I can do it.
Of course.
And even a good radiologist to say, look, we can say whatever we say on image, but you've got to do it in conjunction with your surgeon and your oncologist.
Right, right, of course.
Yeah.
But all those comments are done. Bruce, please.
My turn. So Mark and
Good
Nora
kiss.
put me to work,
Yes, exactly.
taking a little break. We'll see yesterday. All right. So I'm now going to torture you by going page by page through the protocol.
No.
No.
They'll
Only a few
revolt.
slides.
Yeah,
Just a
we're
few
going to go through
slides
this whole booklet.
to try to clarify the reason why the protocol might have been written the way it was. And Karen, to answer your question, what we tried to do for this phase 3 registrational global trial was to mimic exactly the protocol that was written for the phase 2 trial where we had good results. So that's really bottom line why the phase 3 protocol was written. Pretty much. Okay.
We'll mic you. Yeah, when we first started doing these programs, we, went through the protocol page by page. But the feedback was so bad that we decided to redirect. No. We saved that for the investigator meeting.
The other thing I just wanted to mention is this protocol is under a special protocol assessment, a SPA with the FDA. So any changes to the protocol, if we amend it in any way, kind of puts the SPA in jeopardy. So we have to be very, very careful about amending the protocol.
But aren't you scared of a lot of deviations then, because it's not standard practice?
We are managing it, and there are some challenges to the protocol, definitely. So, and we'll take it through some of this. Technical difficulties.
Do you think of specific deviations?
Specific area?
Can you hear me now?
Yeah, the fact that you, like usually when you adjust doses, you keep them on the lower dose, the patients, and then in this trial you have to go up again and down again. You have to consider day 1, 8, and 15 specifically.
No, so we're not having some relevant numbers of protocol violations or deviations to that.
Yeah, and one of the reasons why we want to allow to be able to go back up again is because it is a clinical trial, and we want to make sure the patients maintain a high dose intensity so that we can, at the end of the day, hopefully get the best possible results. And Nora, I think you're going to discuss that a little bit, right? Yeah. All right, so before I jump into the few slides I do have, I wanted to kind of lighten it up a little bit, maybe step away for a few minutes from the technical aspects of what we've been talking about and ask a question. Who knows what Maestro stands for? And we did give you a cheat slide earlier. It's in there. All right. Well, I won't make you look it up. But, because I can never even remember this myself. Without the slide, I'd never be able to tell you what it stands for. But what we did is we put the title through, you can get these acronym generators on the internet. And you type in your protocol title and it spits out all these fancy words. And lo and behold, Maestro came out. And we thought that's a great name for the trial. And it's evaluating TH302 in the treatment of M, metastatic, or locally A advanced, unresectable ES, pancreatic T, adenocarcinoma RO. Who would have thought? That's where Maestro comes from.
We wouldn't have thought. That's
right, okay? However, now you know, now when you hear Maestro, right, you think of TH302 pancreatic cancer, right? If I were to ask you in the hallway, how's EMR 200592-001 going? You'd have no idea what I'm talking about. So it's just a little, name recognition. Anybody know what this little symbol, why we have that little symbol?
The measure.
Okay, Maestro.
It looks like a pancreas as well.
It looks like a pancreas? That's the first time I've heard that. I like that. Yeah, okay. And we also have it on our ties and scarves, and my colleagues have humored me for a few meetings by wearing them. These guys keep saying they forget them, but I don't believe it anymore. So, if you like our ties and scarves, we do have them for sale out in the hallway after the meeting. No, I'm only kidding. All right. So now let's get back to the real stuff. All right. So I'm just going to cover some of the objectives, and then I'm going to go through some of the key inclusion/exclusion criteria. So the primary objective of this trial is to hopefully show overall survival when we compare gemcitabine with TH302 versus gemcitabine with placebo. Okay, so that's our primary objective. And previously untreated, again, we want to be careful with that untreated in the title because that has confused some of the sites in the past. It's untreated except for, and we'll go through those as we were talking about a little bit earlier. So previously untreated, locally advanced, unresectable, or metastatic. And again, the locally advanced, unresectable differentiates us a little bit from, say, the nab-paclitaxel, because that's only been approved for metastatic. Okay, so that differentiates us a bit.
Also, for the UK guys, the SIEGE trial doesn't include unresectable disease.
Right.
Right?
Yep.
So that's only metastatic as well for those who have it, right?
Yeah, but you could perceive that as a weakness of the trial. If you look at median survivals, they're very different across those two groups.
Right.
So in interpreting your results,
was stratifying.
Yeah.
Mm.
Yeah.
You're stratifying
Yeah,
for it.
stratifying. And the other reason was to try to open it up to include as many pancreatic cancer patients as possible.
Well, makes
Right,
recruitment
to help with
easier,
accrual, right,
without question.
exactly.
Yeah.
Yeah.
You would expect a little better
Right.
PFSOS.
Yeah.
But ideally, if we have a positive trial, then this will be part of our labeling
Label.
claims too.
Mm.
So that hopefully will help
Big
us.
difference, yeah.
Right. Our secondary objectives is to continue with the efficacy piece and to look at efficacy in respect to progression-free survival and objective response and disease control, right? We're also assessing patient-reported outcomes, so some quality of life questionnaires. There are 2 different questionnaires, the QLQ-C30 and the EQ-5D-5L. Mainly, we're doing this to help with reimbursement outside of the U.S. because many of the regulatory agencies require that for their reimbursement approvals, okay? We're also looking at pain measured by a numeric rating scale. And then as with all trials, safety is always a consideration, all right? So that's a secondary objective. Some of the investigational objectives that we're collecting data on are running tests on CA19-9, hopefully to be able to show some correlation with the efficacy of TH302 and the decrease in that tumor marker. We're collecting samples for PK, and many of you may say, why are we doing PK in a phase 3 trial? Isn't that something you do earlier? It's been requested by the FDA because we didn't have enough data in our earlier phase trials, okay? So we're continuing to build that database in this large phase 3. We're also going to be collecting samples for pharmacogenetics, which requires a separate informed consent, as I'm sure you're all aware of. So we have 2 informed consents. And then we're also collecting samples for predictive biomarkers to hopefully be able to identify a biomarker that's specific for hypoxia, all right, that we can help, that will help to tell the story in the end. Those are our objectives. Simple? Questions? No? Okay. The trial has been designed, again, based on our phase 2 trial. It's a pretty standard randomized blinded trial design. We have 660 patients that we're looking to randomize by the end of this year. As Mark had mentioned, we're already halfway there at 330. They're going to be randomized in a 1-to-1 fashion. So 330 patients will go to gemcitabine plus TH302, and the other half of the 330 will go to gemcitabine plus placebo. Patients will receive either the TH302 or placebo at 340 milligrams per meter squared on day 1, 8, and 15 of a monthly cycle over a 30-minute period. Then they wait for 2 to 2.5 hours based on some preliminary, some of the early animal preclinical data that suggested that that was the best time frame, okay? And then they receive gemcitabine at 1,000 milligrams per meter squared, again on the same day 1, 15, 18 monthly cycle, all right? And then as Martin mentioned, we do some stratification for extent of disease, performance status, and then region. Okay. Key inclusion criteria, obviously, has to be an adult. Again, locally advanced, unresectable, or metastatic, proven by histology or cytology. And then here's the previously untreated piece with chemotherapy other than, and again, the reason it was written this way is to try to be able to include as many patients as possible. So patients can have radiosensitizing doses of 5-FU, and there's no specific time frame for washout for the 5-FU. They can have radiosensitizing doses of gemcitabine if relapse occurred at least 6 months after the completion of the gemcitabine, so you need that 6-month time gap. They can have the neoadjuvant chemotherapy if relapse occurred at least 6 months after the surgical resection, so again, that 6-month time window. Or adjuvant chemotherapy if relapse occurred at least another, again, 6 months after the completion of the chemotherapy. All right, and again, written that way so that we can try to include as many patients as possible.
Just to comment that the sample case we had previously with who receive FOLFIRINOX here in sort of immunodetention. That's not covered by this protocol here,
Right.
unfortunately.
Measurable disease or unmeasurable disease, again, to be able to include as many patients as possible, determined by RESIST 1.1. ECOG performance, good ECOG performance or performance status, 0 to 1. Okay. Again, we didn't go with the performance of 2, again, because the phase 2 wasn't designed that way. We wanted to be consistent. And 2 observers have to assess that. And it can be the PI, a study nurse, a PI, a sub-I. Doesn't have to be 2 MDs. Okay. That second person, though, does need to be listed on the delegation of authority log with Covance. Life expectancy of at least 3 months, and then, of course, acceptable liver, renal, and hematological status. Those are the key inclusion criteria. Key exclusion, and this goes to, Martin, I think you mentioned this before, the COPD. Because the mechanism of action is hypoxemia, we want to make sure that we're not including patients that may be at risk because of COPD and needing supplemental oxygen. So it's just a safety precaution. Major surgery, other than diagnostic surgery, within a month prior to the date of randomization, or treatment for pancreatic cancer with radiotherapy or surgery like a Whipple, again, within a month or 28 days of randomization. These next 3 exclusion criteria were mandated by the FDA through our special protocol assessment. So when we submitted the protocol for review, they came back and requested that we put these 3 exclusions in for safety reasons. The first one is cardiac related. They wanted to make sure that we weren't including patients that were taking medications that prolonged the QT interval, and, it's not or, it's and, so they have to have both, prolonged QT interval and have a risk of TDP, okay? And then there's a list in the protocol that gives those medications, all right? And then the next 2 bullets are associated with the metabolism of TH302. TH302 is metabolized through the liver, through the cytochrome metabolic pathway. So they wanted to make sure that we excluded patients that were on medications that were moderate or strong inhibitors of CYP3A4, or subjects taking medications with a sensitive substrate or substrates with a narrow therapeutic index of the next 3 cytochromes. Okay.
Can I just say that our one recruit, we managed to get her on with a pacemaker. We had to go, I don't know how our PR managed to do it, but she had a pacemaker, and therefore we felt...
I guess that's a backup, isn't it?
So we said... and
you don't need to worry about your QT, because you've got a pacemaker.
So I'm just going to say, if you've got a pacemaker, you can ignore the QT. I'm not saying that. You have to ask the monitor whether it's allowable, but it was touch and go.
This one needed a pacemaker.
Yeah.
Right. Just to mention that we had some discussions about use of granisetron, because granisetron has in the SPC a description of increased risk for torsadic bond. So we consider this to be not permitted. And the discussion then is, so isn't that a class effect for the HT3 antagonists? And that is a very difficult question, because as far as I know, the other HT3 antagonists don't have this this increase of torsadic risk. They just have the QTC prolongation. Yeah. So when using a very strict interpretation of the protocol, in my understanding, granisetron is not permitted, but the other HT3 agonists would be permitted. Also to add that the clinical evidence or the clinical hints for any QTC-related toxicity are not there. We don't see that. This is based on the observation of 2 patients in one of the phase 2b trials who developed a prolongation of QTC under treatment with one of these combination regimen, and it could not be clarified whether this was attributable to TH302 or to the combination protocol. And that was the reason why this restriction here is imposed into this trial. We are running in parallel a QTC study, a dedicated one, where we, what's being done there. A couple of patients are taking ECGs every, well, not 10 minutes, but like that, yeah. So, and so if it comes to a registration, we will know whether there is something in interaction with QTC or not. I would expect it's not. Based on the clinical data we have, we don't see any sudden cardiac deaths or torsade point reports. We don't have that.
So if I were to say what is the biggest challenge for the sites based on the feedback that we get, essentially these 3 bullets as far as the lists of medications that are prohibited. The lists that are in the protocol, I'll be honest, are not comprehensive. They're not totally complete. So we're trying to do, we're going to be working with Covance, and you should be getting an updated list laminated for your sites that have additional medications. Okay, again, it may not still be totally 100%, but we're trying to improve the situation for the sites to help you out. I think the best advice I can give you is if you have a pharmacist at your site that you can work with, partner with, they're the best resources to help you identify which medications are allowed and which ones are not.
Just to add that there is a problem with providing you with a list, because you might consider the list as complete.
Right.
It never will be.
That's
yeah.
right.
We do, this is a global trial, conducted in how many countries?
24 countries.
So there's compounds which are maybe licensed only in certain countries, which we're not aware of. Yeah. There's new compounds coming into clinical practice.
Different
which
names.
May not, So that is the problematics of providing you with a list there.
Yeah.
So the list will have the heading frequently used. Yeah. It will not be comprehensive.
Yeah.
That's more for the CYP2D6
Yeah.
and C9
Yeah.
because the CYP3A4, that's something we have to look out for in most of the trials these days.
Yeah.
I think. So
Yeah.
that's-
And that's an interesting point, because this is not just unique for the Maestro trial. The FDA more and more frequently is having sponsors build this into their protocols for safety reasons, particularly the cardiac piece. Yep. Okay, I think my last slide. Simple and sweet. Any
Okay.
other questions? Much better than going page by page.
Exactly.
We'll leave that for the investigator.
Straight to the pen.
Perfect.
So the next part is really, I just want to ask questions, because you again all are pretty close to having patients on or have patients on trial, so you're all experienced generally on the trial. But this aspect of dose intensity and maintaining that, have you had patients, we've heard thrombocytopenias come up. Has neutropenia been an issue? And can you use GCSF to help alleviate or mitigate neutropenia in patients on chemo when they haven't had neutropenic fever already? Is that a restricted usage of GCSF in that setting? Would you have ability to do that? So one of the important aspects is maintaining dosage of the study drug and trying not to decrease due to toxicities, particularly the neutropenia, which may be one aspect where patients perhaps could be assisted by the use of GCSF permitted per ASCO guidelines for use in prophylaxis. Does that come up at all? And Radmila, in your patients there, have you used GCSF at all? Or
We don't like to use GCSF.
don't like to? Have you had to
in
dose?
palliative setting.
Pediatric setting, you do.
Palliative setting.
Oh, palliative setting.
Yeah.
Because it's a palliative setting, then you're not using
Not
GCSF?
so often.
Okay, not so often.
But we had more cases with the thrombocytopenia than with neutropenia.
Thrombocytopenia
Yeah,
more than
yeah.
neutropenia.
It was
Okay.
more
Karen as
profound.
well.
So it's the same, we had like a dose reduction, but then in the
Yeah, then you're reading the
Reintroduction,
protocol
yes.
and you're adjusting.
Yeah, so we never had longer problems for neutropenia. We didn't have very low neutrophils.
Uh-huh, uh-huh.
And we
Okay.
would have a problem with the GCSF.
Of using that. Okay, okay.
How
So
do-
that's not going to be. And how about in the UK? Sebastian,
I don't
any-
know yet.
Don't know yet.
Well, one,
Would
I
that
don't know, but two, in terms of GCSF, it's off patent where we have it. It's cheap as chips.
Yeah, we can.
Okay.
So one, we give it,
Okay.
and two, we have no problem with giving it. We give it in palliative setting because, well, it's not just in a trial. We give palliative. We give GCSF in palliative settings. If we, depending what the goal is, of course.
Yeah.
In a trial, I think we would try and keep them within trials.
Yeah. Okay.
Now it's generic, big difference.
Yeah. Yeah. So again, if as much dose intensity that you can maintain on the trial is appreciated by the sponsor to keep the dosage levels up and on time.
How do we look after the skin toxicity? Are you coming on to that? Or?
Yeah.
Yes, so the skin aspects, well, let me just take one brief stop. These are expected adverse events, and these were recently updated at at a safety meeting conducted for the trial. So the main events that are being seen most: myelosuppression, skin reactions, skin and mucosal lesions, mucositis, and GI toxicities, and these are less common but occurring. One aspect just to bring up, we had a discussion one of our last meetings on giving the drug through peripheral veins. There was an impression from an investigator that this drug must be only given after you've placed a central line in a patient. Jolie, is that right? Or is that?
I agree.
Have you been doing that? It's not required. You can certainly start the drug, but there is some venous irritation that can occur, so that is one aspect to be considered. But again, patients with pancreas cancer need to start therapy. So, if you need to start, it can be given through a peripheral line, and then to try to perhaps insert a port or some kind of central line that may facilitate things. So we just bring that up because that's been another investigator's experience. But one aspect that investigator did was he didn't enroll on Maestro because he couldn't get a line in fast enough, or that was an issue for that patient.
So just jump back to that slide, that safety slide. Just to let everyone know, I meant to mention this. We did have our first ISMB April 30th in Chicago, and the ISMB had determined that there are no safety issues and that we are to continue the protocol without any changes. So that was good news for us.
Yeah.
Good, that's important. So briefly, to jump onto the skin lesions or skin reactions, Nora Boyer is the Executive Director of Medical Affairs at Threshold Pharmaceuticals and is a key resource for if you have patients with skin lesions and if your colleagues at your site have skin care needs some review of that information. There's also a video about skin care management for Maestro that's available that she also created. This is a book that is available for all of you today that is created by Dr. Lacouture and Nora, who worked together in creating the guidelines that are also in your handout book today, those little algorithms that are in there. And we're going to go through each one of those before we but basically, the reminder we wanted to tell you is certainly any skin reactions are preventable. And I know all of you with patients on the trial hopefully are the skincare guidelines being implemented at your sites for your patients? Are the patients following them as far as you know? So it doesn't sound like skin reactions have been a major problem for anyone on the trial. Okay. We did want to remind you skin reactions are not unblinding events, so you can get skin reactions from gemcitabine alone. And skin reactions related to study drugs, skin reactions, really any patient on chemotherapy can have obviously issues related to the skin. And I know clinically that's something that we often don't think about prophylacting or prophylaxing in terms of preventing skin abnormalities or skin lesions. So please remember that it's not specific to the study drug and does not unblind the patient necessarily on the trial.
Or just one comment on this picture here. So this was a patient from one of the previous TH32 trials who took a hot tub bath on the day of study drug administration, and that was the result. So that's why in the details to, for example, this skincare, it's recommended not to do that on the sink.
That's really interesting,
Yeah.
though,
Yeah.
because
He
you'd
didn't
imagine
fall.
a hot tub bath would induce vasodilatation,
Yeah.
and
Yeah.
therefore you get less hypoxia in the skin, but you're getting a bigger reaction.
So a lot,
Counterintuitive, yeah.
a lot of the guidelines are, again, to apply the sunscreen and the emollients and things, particularly in treacherous areas. So it's a selfie, yeah.
It's a selfie.
Yeah. So, any questions on skincare? Does Sebastian, do you need more resources, or your site need more resources on skin management or prophylaxis? Or?
You learn these things as you go along. I was just talking from experience with other drugs as well, and managing skin toxicity is...
This is your resource.
Yes, exactly. Yeah. No. And managing skin toxicity, you know, it can occasionally be a problem, and I appreciate the requirement to keep up dose intensity, etc. But you know, we've got long experience with various things like cetuximab, etc., which can limit what we do sometimes.
Yes.
So that's why I said I don't know yet. I was talking about I wait to see what the experience is with this drug.
And the mucositis can be avoided with the use of cold ice chips, ice cold drink, popsicles, the frozen ice, cubes or juices. People
Appreciate
can
this though,
suck
because
on during
it covers quite a lot of things.
treatment. So.
Yeah, and if anybody ever has any kind of skin issues that you're having difficulty with, we have access to Dr. Lakator through Nora Boyer at Threshold Pharmaceuticals. He is really very helpful, and he's always willing to reach out and work with any site that has some issues. He's pretty much dedicated his whole practice to patients, oncology patients that are on chemotherapy and are having skin problems. So he's a great resource.
And so hopefully this book also apply to any of your patients on treatment.
Thank you.
But it sounds like most of the
Doesn't sound like
potential skin issues have really been managed quite easily in this room. I mean, the grade 3/4 is 3%. It's low. It's different, but it sounds like the ice chips, the ice packs, and in the areas that may be most susceptible to the rash are working if you're doing it.
Any experience from the high accrual with the skin?
It was surprising for us to see no skin reactions.
No.
actually.
Did you use the
We use it.
preventative?
Yeah,
Okay,
every
so
time
you-
by administering the treatment we use it. So it's sometimes confusing for the patients because
that
they
right?
get a lot of stuff.
It's a lot of ice
So-
packs under your
Yeah,
if you
I
do
think-
the under the armpits and the groin.
Yeah.
You always know who the TH302 ice person is, the one sitting on the ice pack.
Smelling the precedent.
Yeah.
Potential.
All right, well, it's good to hear, certainly, that the drugs sound to be well tolerated. At least the study therapy is well tolerated. So we'll do a couple cases and then we'll finish up. And Kaikin was going to give us some follow-up on some cases he presented for us at one of the other workshops. But let's move to this one since he's not here yet. This case was presented again by one of the sites in Hamburg, and this was a patient, 72-year-old woman who had a previous Whipple, basically, September 2012, for her presentation, and then received adjuvant gemcitabine therapy completed May 2013. August 2013, no evidence of recurrent disease, but then in December showed evidence of pulmonary lesions as distant metastatic disease. So do these cases, first of all, I presume if they've received adjuvant treatment, they're followed now they're one of your patients? Is that basically, they don't go back to surgery, or they're followed in the medical oncology or the GI oncology group?
Given the statistics, well, you might tell us surgeons, but they're going to come back to you.
But we try
In
and
that
teach the
setting.
surgeons that they should look after their patients as well.
Ah,
So unless the patient insists,
yeah,
we actually try to at least do.
You discharge them?
We're in discharge, open appointment.
of course, come back.
Because it's going to come back within 12 months.
Yeah.
But we try to get the surgeons because they are the ones who did the massive operation.
Yeah,
A
of
percentage
course.
of them will be cured, so we
Right.
don't want to be looking at. We've got enough other
Right.
metastatic.
I'm a sucker, I still follow my
Yes.
Are you? It's like bringing the 10-year breast cancer survivor back. How frequently are you following the patients you've had post-Whipple? 3 months, 6 months?
6 months, maybe.
6 months interval, okay.
Yeah.
Sorry,
Everybody else sends back to the surgeons. I've got to learn.
3 months.
Well, what about the rest of them? Are you sending them back to the surgeons over here in Belgium, or do you follow them?
No, we follow. We follow.
You follow.
See, they follow.
And did you say every 3 months?
Every 3 months.
Every 3
Every
months.
3
months. Okay. So is this a patient that would be a candidate for a trial like Maestro? So they had adjuvant treatment before. So a couple issues. One is obviously now does the patient meet the protocol specification? But the other question really is, again, could the patient be a good candidate for randomization to either of the study arms of the trial? And are you comfortable with that? Is that at all an issue for? Have you had patients in this setting enrolled on this study? Is this like one of your patients, Francois? A case
sure.
like
We see, as I told you, I consider it as a palliative surgery, and usually we see them coming back with those lesions.
Yeah.
And
Okay.
that, I think, well, you say that should be 6 months between, but it's almost 6 months.
Yeah, yeah.
It's more, so it's an eligible patient.
So the randomization is still an area that you're comfortable with in terms of this trial. Yeah. Ron Miller, do you see cases like this as well?
Of course.
And is this a situation, again, we talked about this, I guess, earlier, so no one really, I guess, views presentation of disease to be particularly distinctive or unusual in terms of how you're deciding what to do for patients, per se. Bulky, treat them one way. Location, treat them another way. If it's pulmonary Mets versus liver Mets, no distinctions. Is that pretty clear? Pretty, okay.
Well,
Symptomatic disease rather than bulky. I mean, I think you asked that question about because of hypoxia, would you treat bulky disease with?
Well, like, okay, for instance.
One, there's no evidence to stratify in that way. Two, you kind of think actually that's quite dangerous because you're kind of trying to do sure, but it's kind of like thinking that you could think that far ahead, that you could say, well, I would more likely give someone who I might have bulky disease with hypoxic areas T8302. I think the more worrying about bulky disease is just symptoms. I mean, whether it's bulky disease in the lung or bulky disease in the liver or whatever, you just worry that they're symptomatic. If they're asymptomatic, I think we are less concerned. But it's all about the first case, wasn't it, Sebastian? The, aggressive disease, or whatever you want to define it as, or symptomatic disease. You've got to get on top of it pretty quickly, and then you might change what kind of chemo combination you give.
this case, I'm not terribly happy with giving gemcitabine again. May to December, and then a relapse from microscopic disease.
But Nora, I suppose that the aim of your question mentioning bulky disease to see if it would be eligible for a palliative radiotherapy or something like this, because I missed the point by bulky or not bulky, if there would be a difference in treatment.
It's really to get an understanding again of clinically. There are obviously, as we've discussed, many options that we could all choose clinically to give patients. And do we make any particular selections other than to say, okay, they all have metastatic disease. Do we make any other distinction in trying to figure out what to do for the patient? Clearly, we know the younger, fit patient, or it doesn't have to be young, it could be just fit patient, first line. Many times FOLFIRINOX is chosen for reasons of the data or experience using that combination. Are there other factors that would go into how you might choose between nab-paclitaxel and like a trial, like Maestro, in terms of how you might distinguish those patients? Your SIEGE trial versus Maestro trial decision.
Toxicity.
What is that decision? So, is it going to be, is there some anatomic presentation or some distinct qualities of the patients that would lean you more toward one or the other in terms of a treatment option?
No, because you're tied down with the performance status, etc. So you haven't really got much evidence for suggesting, the bulk of the disease and its relationship to hypoxia or the sites of disease. There isn't anything really beyond perhaps something theoretical to direct you there, and that's a weak standpoint to take when you're deciding.
Correct. And I'm not suggesting that's how you should select patients. It's a question.
In summary,
it's a question.
But one thing that could help you define, because what you're saying, okay, so you've got these choices, And because of the nature of the trial, as I understand it, because of the nature of the trial has been set up, etc., and what's come through subsequently, you're faced with, sometimes a difficult decision to make in a PS0-1 patient. Well, one difference that I can see between nab-paclitaxel and GEM and FOLFIRINOX we've talked about, but nab-paclitaxel and GEM and the trial is the toxicities. There's a different pattern of toxicities, and that's something which I think could help you refine which patients you're going to select, etc. Obviously, there's individual patient histories as well. So this one, for me, neither necessarily would be my first go-to because she's just had GEM and she's relapsed very quickly.
So aren't you afraid that that could bias your results? Because as Sebastian said, it's a patient who has proven not to be responsive or not very long responsive to gemcitabine, and
this is microscopic disease which is relapsed with macroscopic disease, in a 6-month period. So,
is there a window that you are comfortable with? 12 months, 8 months?
Normally it is 6 months, but
I mean, just to comment on the 6 months, obviously this is the minimum period. If you're not comfortable with that, of course, you need to be comfortable with your treatment decision.
well, it's just, is there something better in this situation?
I mean, the 6 months is coming from discussions we've had with pancreatic cancer physicians, and also in other diseases like ovarian or small cell, 6 months is considered a period where if a patient had received the same drug before and is relapsing later than that may indicate that the disease is still sensitive to the compound.
No, sure, and we do it repeatedly.
But if you feel more comfortable with 9 or 12 months,
we do it with
totally
lots of different diseases. But in the adjuvant setting, when you've just completed adjuvant therapy, it's different from you've just treated them with metastatic and then they relapse. I agree, and you're not given a huge wealth of alternatives, shall we say, in pancreatic cancer. So yes, you've got to use the tools you can as best you can. But we know there are other active agents, fluoropyrimidines, platinum-containing agents, etc., as we've all talked about, which might. Well, yes, I agree. It's feasible that you could use. Okay, I agree. You could put them back for gemcitabine. It just wouldn't be my first thought. I don't know.
I think it's a consideration.
That's fine.
Yeah.
But still, I mean, I think we've all been trained in the platinum sensitivity, platinum resistant world, right? Where you could reintroduce a platinum agent after 6 months and be considered sensitive disease, but anything under 6 months you're considered, resistant disease. But it's arbitrary, really, right? Obviously, the longer you do, whether it's adjuvant therapy or frontline metastatic, reintroduction of the same chemotherapy, the longer the duration of, no relapse, the better off the patient's going to be. But here you don't get a lot of time, so you want to use as many options as possible.
No, I see what you're saying there.
I mean, the only thing I would say is that I forgot that case from time, but the option still is to do nothing. I mean, I don't know how big these pulmonary lesions are, but if there are many of them, but if they're very small and they're asymptomatic in a 72-year-old, you could say, well, why don't you just do another scan in 6 to 8 weeks and see how you are? That's one thing you can do. 2, in some ways, it's the ideal. We talked about like your ideal trial patient. Okay, this person has got small volume lung metastases, and whatever trial medication you do, if they get the active agent, you've got a volume of disease that you're going to get a good RECIST response in whatever. Okay, equally, you've got a lot of time to rescue this patient. So if you put them on Maestro, which I agree is probably more of a patient-delivered thing, because I think there's a bit uncomfortable for me to say, I think it's going to really work. But they might get the active agent, and even if they don't, you're going to scan them in 8 weeks, and if it ain't working, you've got definitely time to move to gem, Abraxane, or reduce dose FOLFIRINOX, or whatever you want to give. So I think the only other option I would definitely say is you don't have to immediately treat this patient, actually.
Which is always a good point to consider as well.
In terms of overall survival.
Interesting,
Right.
So I think the discussion you have with the patient...
You need to put an image up.
Yeah. Harvey, please.
So I think the discussion you have with the patient then is the important thing, isn't it? Laying out those potential options.
Yes. But I think,
She's 72,
trying to define, obviously for each patient, what are those options, and clearly we give them options, as I mentioned earlier, because we don't necessarily know the right choice for a particular patient. You know, there's pluses and minuses to everything. Is every FOLFIRINOX patient I treat going to get 11 months, you know, survival? No, not necessarily. Is every nab-paclitaxel gemcitabine patient going to respond and have, you know, what
You know
I
what? I think I'm influenced by colorectal experience. For me, it's, for me, a relapse at that point is.
There is, yes, I didn't want to continue the rest of the case, so that patient was
I
on.
just read this as well.
To give you the rest of the story. Kakin, do you want to give us an update on this patient?
Yeah,
who
so
was
this
not
is actually-
treated on Maestro?
So I presented this patient when I was in Paris. Unfortunately, we didn't have any patients. We couldn't even screen them at that time, but we gave 2 contrasting cases, just really because they're quite interesting, and I think these are things that you'll see, and how we decided how we managed them in reality without the trial, and maybe what we'd have done if the trial had been open. So this was a 64-year-old man. I think he was an ex kind of film director, very fit, has active life in every way. However, he had diagnosed with diabetes by his GP about 6 months prior to presentation with PEs at a district general hospital. They did a CT scan and then didn't really look at the bottom part of the scan, and then suddenly someone said, "Oh dear, I think there's something not quite right." And then he wasn't that unwell, but he was good performance status. He had been treated for his PEs, but he had scans and biopsies, PET scans and everything. He's got widespread disease. So body of pancreas, bilirubin was fine, I think. He's got lots of lymph nodes, liver, lung, bone mets. Actually asymptomatic from everything. It was mainly his PEs that he had been symptomatic from. So he has got an unremarkable CA99. So as you know, CA99 is not always very helpful. And album's okay, he's on clexane. Right. So yeah, he's got some right shoulder pain. We couldn't work out what that is. Probably the liver. It's probably the liver. Anyway, so that's how he presents.
So tell us what you chose or why, and you know what options. Clearly, this tells you, so we won't go back.
Well, I mean, there's more better. So what would you guys do? I can tell you. Why don't we just say what would you guys do, and I'll tell you what we did.
Yeah.
So this is a fit 64-year-old PS. Well, actually, I would say 0 because he's still doing what he wants to do, although he's got some shoulder pain.
So I'd probably talk to him about whether he wanted chemotherapy or not, and then if he wanted chemotherapy, he would be a candidate for FOLFIRINOX from what I can see there.
Because he's performance status 0?
Yeah, he's got metastatic pancreatic cancer, he's PS0.
What is PS1?
Yeah, that's what I think. I think he's PS1. Well, he's got minimal symptoms, so he's PS1.
Okay.
He's got symptoms.
Okay. Would you lean less toward FOLFIRINOX in that situation
No,
and more
0 to
toward
1.
something else?
It's reasonable.
Okay. If you were 70 years old, would you still think in the same way?
Well, he
Performance
might be
status
biologically a bit
70-year-old
older. He's been
patient.
smoking for 30 years, so he might be a bit older than
Now
64.
some other factor comes in. So 64, smoking 30 years, performance status
Well,
1.
you can't tell until you see them in front of you. No, seriously.
No, it is true. Yeah.
So you can't do it. You can't do it on the number.
That doesn't mean anything.
2 girlfriends.
Really?
Very active life.
Well, go away and enjoy your time
Smoking
then.
ain't affecting one part of his body.
Yeah. Well, then don't have the chemotherapy. Go and enjoy yourself.
Yeah.
No. Sorry.
So does anyone else use a cutoff, or what kind of criteria for FOLFIRINOX selection versus nab-paclitaxel? Geraldine, at your location, is there a particular, I know every patient is different, but do you start thinking less about FOLFIRINOX based on age or symptoms?
It depends
or
because the age is not the main criteria. You have people with 75, 65, so it depends. No, it depends.
The age not the particular
No.
factor,
Maybe
but other
not at
aspects.
80,
Not at 80, okay.
but
Okay.
yes.
And do they have to be pretty pristine in terms of physical symptoms? For you to feel comfortable, I can give FOLFIRINOX and be aggressive. And
It depends because here you have liver, lung, bone.
that's everywhere. nodes, liver, lung, bone.
I'm not sure I would give something only with the Gemza. No,
Not a
kind
couplet of
yes,
Gemza or
yes.
something. Yeah.
Because
okay.
maybe it will, Gemza is not effective, it will be difficult to give something else after that.
Would anyone in this case feel like Maestro is a possibility for this patient?
I think sure, and
Yeah.
actually certainly is.
Sir.
And I would have the same way of thinking as you did, Dr. Shu, because after 8 weeks, if it seems that he's not responding, we can still swap to a FOLFIRINOX. It's presented as an obvious patient for FOLFIRINOX, but taking into account all the secondary effects, it's worth starting. It's probably what we should do in the environment we're
So
in.
you may make him worse off with first-line FOLFIRINOX
Could be.
related to toxicities or something.
I mean, he's a candidate, but if you're working on the basis of survival and response, then single agent GEM is inferior to GEM, nab-paclitaxel and FOLFIRINOX. That's the trouble. That's the question. It's not the investigation, it's the randomisation to single agent GEM. That's the only question, and that's the thing that a patient has to be aware of. They'll gain in terms of toxicities being lesser.
But after 2 months, 3 months,
You'll know.
he has a PS of 0, you still have time to swap. No?
Hold on,
You're
this,
right.
this man's presenting with disease everywhere. You're assuming that in 2 or 3 months he's going to be fit for a haircut. You know, it's a gamble you're taking with him. And that's all.
Yeah, so we go on our, as I said before, the way we do it, don't show it yet. No, it's just, it's an interesting
Yeah,
case.
cat's
So
out of the
we
bag.
would, with this guy, we actually agree with everyone in the room, because what you do is, it's a good performance aid is you give them all options that you have available. So you would say GEM by itself, single agent, not very toxic, not on a huge amount of disease control. FOLFIRINOX, much more toxic, better disease control. And we would offer, when we did, or we would have, and I said that we would have offered him Maestro, but with those caveats, you know, with the fact that, hey, you know, we can still salvage you with FOLFIRINOX, but, you know, actually at the end of the day, and you might get a very novel agent, 50% chance, and you go for it. So, and if at that time nab-paclitaxel was there, nab-paclitaxel was there, we would have offered him everything, and then decided, you know, next week, what do you want? So he was these kind of guys who says, I want to live forever, I'm going to take what you give to me. We gave him GEM and FOLFIRINOX information, and the following week said, I want FOLFIRINOX, so we gave him FOLFIRINOX. I don't think it makes any difference. I think it's come around the room that age in itself is not a big deal. It's biological age. As you know, in Accrual, they treated up to 76-year-olds, and we treat 70-year-olds with FOLFIRINOX. You know, 72, 73. It depends, you know, how fit they are, what they want, and we can reduce the doses if necessary. I mean, do you guys use age per se? I don't think any of us really do, do we?
Now
Okay,
we'll show
so unfortunately I can't show you all the disease, and as you can see, he's got extensive disease in his liver, and you've got to believe me that the radiologist said that pre-cycle 5 is actually a response. It's just the disease
It's
has
perfusion,
changed. The
isn't it?
texture, it's a perfusional change, and then he did very well. He had full dose up to cycle 9, I think.
Wow.
And at cycle 9, he was starting to get some toxicities in terms of just fatigue and some myelosuppression. We gave him GCSF. And then, that's his scan. Is it after cycle 12? Can you just click it one more time?
I don't know if I put it in there. Oh, I did.
Okay, so that's the scan at that level of everything, and you'd say, well, actually, he's responded. But the radiologist said, actually, in the upper dome of the liver, he's got 3 new liver lesions. So he's actually progressed. He had actually had disease control absolutely on every other side, but he has these 3 new liver lesions. And so, you know, by that criteria, got to stop, right? And he's still very fit. So what we did was we would have offered him, well, you offered him GEM, second line, because we don't believe in GEM cap or anything like that. Unfortunately, despite all that stunning response, and we gave him GEM, within 4 weeks or so, a month of GEM, he came back with headaches, had multiple brain mets, died within 2 weeks. And he wasn't even well enough to have whole brain radiotherapy because he was so confused and agitated and unwell. Well, so, you know, that is an unusual case. What would have happened if we had given him a trial? I don't know. But you know, from our point of view, it's just an interesting case. You know, and I think who was there said that is an unusual response to fulfillinox, but then we were talking about very good responses on fulfillinox. So in some ways, that was a very good response. Would have anyone done anything different in second line? I'm just interested.
We've had a long conversation about carrying on at all, actually, in that context, but apart from that, no.
I mean, he wanted to go beyond 12. If it had been beyond 12, we've never done it. We've said the trial shows don't go beyond 12. But believe me, if he hadn't got, we would have probably, I'm not saying we do a Chiro 3 maintenance, but we would have reduced doses of fulfillinox and maybe continued. You know, we don't know. We can do what we want because it's not a CDF drug.
But you wouldn't know, or would you, how would you feel, as you said, you don't know what the patient would have done on reduced doses of combination
I would have been very comfortable with a treatment break, believe me. We'd have said, we recommend a treatment break. If he completely insisted, knowing that there are non-toxicities or whatever, we would give him chemotherapy.
So the patient, he was pretty stable, I guess, within the first couple months, which is the interval of evaluation on a clinical study. So you had mentioned when you presented the case to the patient, it came down to the two options, because you didn't have at that time nab-paclitaxel was not funded, and you didn't have basically is fulfillinox or Maestro if Maestro had been open. So would you have been at that time comfortable with enrollment to Maestro and then fulfillinox quickly in the second line setting? Because it's only 8 weeks into a course of treatment.
I mean, we're comfortable if the patient's comfortable. Okay. I mean, the fact is that we can't guarantee that he's fit enough for fulfillinox in 8 weeks. We just don't know.
Yeah.
But
like you can't tell how the patient's going to do on fulfillinox either.
He might have done very well with gemcitabine
or at
that time. So again, I think it's all about fully informed patient choice and options.
And is that? Go ahead, Mark.
So this looks like the responses with fulfillinox, at least in this case, don't come at a quick pace. So they're rather a bit protracted. Is that
well, I don't think so. In fact,
I mean, if you compare pre-chemo versus pre-cycle 5, I mean, this is...
You said he was responding
that's
here.
A response, so you've got to believe the radiologist. That's a
perfusion
effect.
Yeah, that's where they die, isn't
right?
it?
So that is not progression. That is actually a really good response.
This is about 8 weeks.
And of course, I've only not shown you the lymph nodes that shrunk, and the primary shrank, and the lung nodules went away.
Is then hemolysis an issue with fulfillinox?
Not with pancreatic cancer, unfortunately.
Cancer. I mean, this
Be nice if it was.
It doesn't work that well.
Yeah.
It's definitely not in the endocrine tumor, by the way. It's definitely adenogloss, bog standard adenogloss.
Okay.
Yeah.
Do you want to move, Mark? What do you want to do? Keep going or move to your?
You can do
part?
right. Either way.
Your other.
Or go to maybe the slide on the one, identifying the right patient.
Let's just do this.
Yeah, there you go.
We've discussed this a little bit. But just to, again, as we're thinking about how to the treatment options and what makes one more appealing or non-appealing to a patient, and how we talk about these options for patients, I think one big question is really, what do the results that we have tell us, and are we really satisfied with what the clinical trial results are now? And so where do clinical trials still fit in? That, non-targeted therapeutics, cytotoxic therapy kind of trials, where do they fit in now still in pancreas cancer? Clearly you're all active on Maestro, and at the time you started the trial, that was at one point in time. Now we've moved down the calendar a bit more. Things have changed and evolved a bit. Rodmilla, do you have any thoughts on how a trial like Maestro fits with pancreas cancer therapy? And for right now, and obviously our goal is to get the trial completed before the end of the year, do you envision any changes in that time with how you and your practice colleagues are going to view the study? Or you'll continue to accrue 8 more patients to the trial?
I think so.
Oh, good. So this trial has still a role in pancreas cancer?
I think so. Yeah.
Just
in our situation, it has a role.
Yeah. And do you think that we can do better than, say, the results here? And another question is whether gemcitabine is a single agent. There's not this 1.24 month survival difference that was in that trial, even though it wasn't really the endpoint of the trial and approval. But again, are we really getting these results when we're treating our patients? And we know what the papers show, what the references say, but do we really see the results with FOLFIRINOX the way that it's published? And Geraldine, in your experience, what are you seeing in your patients as you're treating them with different treatment options?
I'm quite young in GI
Pancreas?
oncology, so maybe I'm not the best person to. But in my point of view, for FOLFIRINOX, if you select, you have a good selection of the patient, it goes well. And
so that's really key.
Yes.
Picking the right patient. Yeah. And different from that than the nab-paclitaxel gemcitabine patient versus a patient who might be a candidate for Maestro. In your mind, are there differences for those two options?
Between Maestro and nab-paclitaxel?
Gemcitabine?
In our unit, we reserve nab-paclitaxel to PS2 people. So
I see. Okay.
There is no point finally.
Yeah, so that's not the patient that you would think of for Maestro. Yeah. So how the patient for Maestro at your location would be, have some characteristics that you can tell us that patient would have?
Locally advanced, maybe older people. Yes, it will be that, and but talking with patients, talking about new drugs, effective drugs, they choose to go into Maestro instead of FOLFIRINOX.
Instead of FOLFIRINOX?
Yes.
Okay, yeah. And then Sebastian, how do you think about the right patient for
I think that,
study like this?
I think this is a really interesting study with a really interesting novel agent, and I think it needs to finish. This study needs to complete so that we can see where it goes to next, because it's not like we have a wealth of other things to treat patients with. So I think there's a real imperative that this should complete its recruitment and satisfactorily, and then things will get more interesting from there, one hopes. In terms of selecting patients for it, I don't, it's not that the other alternatives are dramatically, it's not that they are the best thing since sliced bread in themselves, and so I don't have too many problems in there is a conflict with some patients potentially, and you have to recognise that the landscape's shifted a bit. But I think it's totally ethical to randomise patients into this group.
And
if you're lucky enough to have, sorry.
Are your colleagues of that same mindset?
I think single agent gemcitabine, as the other randomisation, is difficult, but you have to. But people who've been working in pancreatic cancer for a while realise that you've got to keep pushing and moving on. There's potential difficulty. Being part of the problem myself in being involved in getting Abraxane available, but I think that I would be keen to take part in this trial, and I don't see it as a.
There's still a group of patients certainly eligible for a trial like Maestro.
We're going to hold you to that.
Harvey, how about at your location?
I'm going to think yes. I'll probably echo what Sebastian said. Really, for that group of patients that you're happy to give gemcitabine to, there is a potential conflict. But ultimately, also, it is about the discussion you have with the patient and laying out all the potential options so that they can come to some decision and helping them to come to a decision, really.
And are you involved with some of that discussion? Do patients call you with questions about
yes, yeah.
what's available?
Yeah.
And how much discussion in terms of toxicity risk goes on about nab-paclitaxel gemcitabine versus Maestro trial?
I don't really have much experience with nab-paclitaxel, but certainly with discussion around the potential toxicities with FOLFIRINOX versus, say, gemcitabine and the Maestro study.
Yeah.
This is some experience of that.
Yeah.
And it is, and I think it's important that, you know, we actually explain to the patients what the potentials are, what the potential benefits are of each, and so they can have the opportunity to weigh it up.
Yeah.
That's sort of our take, really.
Does any clinician here feel there is any survival benefit with gemcitabine monotherapy? And anecdotally, have you seen?
Oh, yes. I've
things?
seen some even had to stop after 1 year because of lung fibrosis. So really well, yes.
Did you go back and check the biopsy? Just
oh,
joking.
yeah, no.
Sorry.
That's good though.
So it's not an impossibility or something that is.
But
In
it's
the
all
case
we
I
have to
skipped over,
offer.
Noro, was my other patient who was on monotherapy gem, and within 6 weeks was asymptomatic from celiac involved.
Yeah, it does work.
CA19-9 almost normalised, and she's the kind of person who you would actually say never stop. I mean, unless you get fibrosis or toxicity, because it's clearly working and it's so non-toxic. And why don't? I mean, there's no harm, and that's the great thing about gem. If it works, it really works, and it's much better than FOLFIRINOX because you know you're going to have to stop FOLFIRINOX. But we don't have to select those patients. You just have to kind of see.
Right.
She may have done fabulously on the trial if she'd been in, because you know
Right.
she'd have done anyway very well, whether she had the novel agent or not.
Yeah. So I think this struggle we have as clinicians to say, well, the randomization is to single agent gemcitabine. You know, I think sometimes because, you know, new data comes out, you get excited about new information, and wow, that maybe looks a lot different. Let's try going a different direction. You know, it's at least at this day and age still a valid, still clinically valid decision to make.
We've got to finish this trial because you know I think the next best trial, and it sounds like really the nab-paclitaxel backbone is going to be a much more deliverable backbone and also acceptable to clinicians and patients to add a novel agent. So Martin, you talked about, you know, you have got a phase 1, which is gemabraxane TH302. That is what we very comfortably
get on to the next thing.
stage. But we might be able to do that, you know, by late next year. I mean, whenever the results are back. And what I would say is I wouldn't review much as an aggressive therapy, but a novel therapy. So that's great. It doesn't have to be aggressive.
It's what we need to do.
It's good that it's not aggressive. If it was super aggressive, we might not want to recruit people with a really toxic trial. And as far as I know, we haven't had any kind of stopping of the thing because someone's died of a kind of hypoxic event. And so, in fact, we would say that's good. It's otherwise safe. I mean, that's good. Otherwise, we wouldn't be continuing to recruit.
I agree. Karen?
I think when I started out, I said that it is easy for us to recruit because GEM is still the standard first-line therapy in our country. But I've had other studies with the issues that are mentioned here that you have to choose for a worse backbone. But I do think that it's kind of, if you accept to participate in trials, you will run into that kind of trials once and again. And it's part of, it's a conflict between the patient before you and the population that needs an answer to a certain question. And you really have to, you know, get yourself into thinking in a certain way about that. Because, and you said before that we sometimes probably, without knowing, send out signals to the patient. So it's really something you have to do in your head. I'm going to propose these options without having a weight in it, putting a weight in it, like this is better according to me, or this is, it's like these are the options. And if you are a patient that wants to go for something new, then you go into the trial. And if you want to go for something established, then you take another choice. It's about the kind of person that you have in front of you very often.
Yeah.
And you're very much in a transition zone right now with this trial. I think, this is my personal opinion, but we've got till the end of the year. As I start seeing the newer trials being developed in the frontline setting in pancreatic cancer, most of them are going to be in combination from here on out. And I would assume that most are going to be a nab-paclitaxel combination. So for those of you who already have nab-paclitaxel, that's a clinical trial option. For those countries that don't, you're able to give a doublet that you would normally not be able to give, right? So I mean, there is and you'll have to get comfortable with it. But I think this is probably going to be one of the final trials, at least in the frontline setting, where gemcitabine alone is going to be, you know, the control arm. All right, so one question I have to ask you, everybody raise your hand. I'm going to ask you to put your hand down when I get to the right number. So everybody's got to raise it. Up. What is old? I need to ask you. Put your hand down when you hit the number that means old. 50. Thank God. 60. 70. No one at 70. 80. Okay, 80, 90.
Old is how you feel.
Over 100. So
I would have put my hand down at 80.
Yeah. The reason why I asked that question is, I don't know if you follow the news, but in America, there was this place called Leisure World, right? And they're actually trying to change the name because what happened was about 30, 40 years ago, people retired at 50 or 55. They were considered old. And they went to this retirement community called Leisure World, right? They did this longitudinal study on these people, which is very interesting. I think we'll see more and more data out of the study on these 55-year-olds who are now 85, 95, some of them are 100 years old, right? And it's amazing that, I mean, the people taking care of them, which were gerontologists, you know, are now internists taking care of these 80, 90-year-olds, right? So old is not exactly as we perceive it. And I believe, like you do, there are some 70-year-olds, 80-year-olds. My parents are 75. And, you know, they still go out, they play tennis, they play golf, they jog, and other people maybe not so much. But Nora, you and I are safe now. That's good.
There were two things, I saw that
Did you
on
see it?
60 Minutes, and there were two things
Yeah.
that stuck in my head that actually works in your favor. Having a drink every day.
Yeah.
And gaining weight.
Exactly. And you're right. So the things I learned was, so teetotalers did not live as long as people who drank.
That's right.
It didn't matter what you drank, just drink a little.
People that don't drink at all.
Weight, if you're thin, you didn't live as long. Actually, carrying a little weight is good. And the other thing was mild to moderate high blood pressure.
Yes.
High blood pressure, elderly in life, you live longer versus low blood pressure. I mean, pretty interesting. And these, they have been following for 40 years.
So we're gonna live forever.
Oh, control high blood pressure. It's always a good thing. Okay, so this is the home stretch. I'm going to go around the room. I'm going to start in Israel with Saloma, because you've been quiet. So I'm going to ask you to answer these two questions. What did you learn today that you didn't know coming into the meeting? Be honest. You might say, I didn't learn anything. Maybe you learned a lot. And then the goal is, remember, we've identified the right patient. Do you think your site, doesn't have to be you, but your site can put on 3 to 4 patients in the next 3 to 6 months? The trial's going to be done by December, maybe even sooner, but we want to make sure everybody here contributes. So I'll put you on the spot first, if that's okay. Good news, you get it out of the way.
Sorry.
Losing your
Sorry
voice.
Yeah.
Yeah.
Well, I learned everything because I wasn't very familiar with the protocol and
Yeah.
it's like how a clinical trial is conducted, and it's very interesting for me to see the oncologists treating their patients.
Different ways in different countries. Yeah.
Exactly, and also the challenges they're facing, and it was interesting to learn to understand the mechanism of action of the new treatment and drug apart of the germs. And I think we have a big chunk of patients with pancreatic cancer in Israel, so I think we can.
You've got one patient on, so a minimum of 3 would be great. I mean, that's one every other month. They do come in batches, but please consider obviously this trial as they come, and certainly you learned a lot being a resident. Good luck. You still have a way to go. What in this country, it's your resident, consultant, professor. In America, it's assistant professor, associate professor, professor, or private practice. Just go into private practice. Just depends. Okay, Radmila, tell us a little bit from the Czech Republic, your thoughts on these two questions.
I think it was very useful also to talk about the inclusion criteria and especially about the Volphrenox patients, and to hear also about the different responses in the Imagine studies. It's very interesting. And it was also good to hear that the toxicity is acceptable also in the other centers. Yeah. And I think we will surely enroll more patients in the next months.
You have to be in the running. I think is the highest enrolling site 10?
No, it's a site in Russia.
Oh, those Russians. Who's got how many patients?
I don't want to say.
We'll have to see. But I think you'll do fine with already getting out of the queue. And it is interesting. I think that inclusion criteria is, as Bruce said, it's inclusive, right? So we wanted to make it as inclusive as possible. And hopefully the cases we showed you, all of them were potential patients for Maestro. But it doesn't mean that that Maestro is the right trial for each one of those patients. But at least to have you understand the nuances, I think, is very important. Well, thanks for your participation today. Let's go to our colleagues from Belgium. So, Karen, why don't you tell us what you learned and whether you think Belgium, your site, can put on some extra patients.
I've learned a lot about how patients with pancreatic cancers are treated differently throughout the world. That people are lucky that some countries still have gemcitabine as a
still a good thing.
Still a good thing, yeah. And it's been nice hearing a bit about the development of the drug molecule and stuff like that. And I hope I can enroll more patients. It depends on the buses.
Yeah. Depends on as they come in, right?
Mm-hmm.
Exactly. I think that's one of the things that everybody enjoys, especially in the small group. Usually, like I said, 8 to 10 participants, is how different you treat patients. I mean, there are obviously very similarities around the disease and life expectancy and the different options, but how people treat the disease, if you have a lot of options like in the UK, maybe more limited options. In the United States, it's very much the same. I mean, Kentucky's like California, like Texas is to Massachusetts. But in the European Union, and you're very close, in the rest of the world, you're still very close in geography, but your practices may be completely different. Yeah, very good. Francois, how about you?
Well, I had the same remark. I worked here in Royal Free for a year, and I remember when I left, I said, it's a good place to work and to be trained, but I would like to be involved in the NHS. I would like this country to get ill or to be sick. And I was quite startled that you have such an easy access to all those different...
I'm quite startled you don't. We presume that everybody else has got it and we don't.
Well, we can have a chat afterwards about the ethics of the CDX.
Yeah, it depends on your politics. Yeah.
From the oncology point of view, it's great, but if you talk to another specialist,
But how long will it take if somebody has a diagnosis of pancreatic carcinoma before he's on your outpatient clinic? How many weeks will this take before he can be seen? And then when the CT scan has made a quite suggestive...
Well, the survival figures are still not great for the UK. I've actually talked with Sean Duffy, who's sort of what we call a cancer czar. Lucky there's no Russians here. But in charge of cancer for the UK. And his interpretation is that diagnosis is made late, i.e. they present late, amongst other things. Once they're referred as suspected cancer, they're all referred for assessment and tests within 2 weeks. There's a strict pathway now. So I'm not sure when it was you worked, but things have improved. But they're not what you call ideal, but they're not that bad. But presentation and education of patients amongst other things.
If you make a diagnosis of a potential resectable pancreatic carcinoma, how long will it take before he's having his Whipple? Because this team ages in our time.
It's supposed to be 62 days. From the
62 days is 2 months.
From the time of
from the referral, from the first letter. So, but that's usually within 62 days.
So that's 2 months.
Yes, usually.
Wow.
Yeah.
It's within a week in our country. So that's exactly what I...
Well, no. Yours will be in a week from the CT. I'm talking about he goes to see his general practitioner. From the time he sits in the surgery to see his general practitioner. And usually, I mean, we don't have no one waits 62 days for surgery, certainly.
I think there's some rules. So once, this is for liver met surgery for Gerrit, I mean, I think they're meant to operate within 4 weeks. Definitely. So it's how quick you can get the tissue diagnosis. And what I found is, sitting in these MDTs, it's the resectable ones that take a long time to work up. And, because they keep thinking, it might be cancer, it might not be cancer, and then always it. And sometimes you do worry that it's taking longer to know whether it's resectable, and you kind of work them up, whereas the metastatics are quite obvious. You've got massive...
I think once they're in the system, I mean, talk about the UK system now, but I think once they're in the system, it's not so bad. It's better than it used to be. It's quite clunky. But no one waits 62 days for primary pancreatic surgery. And we are talking about measuring it from when they first walk into their general practitioner's door. That's when the clock starts ticking, when he makes the referral. So if they get through to, we'll see it in our, what we call an MGT or a tumour board or whatever. They'll be pasted for surgery, then in our centre it's within 2 weeks usually.
So what I learned is that we have the ideal environment to recruit because we only have gemcitabine to offer as the standard of care. Okay?
I think well put, Francois. I mean, if you have to get comfortable with potentially randomizing to gemcitabine alone. And if that's your only option, then that's, you may be comfortable there by default. And as we said, in the future, it'll probably be a doublet that you'll randomize to, but there's still the right patient that is just a gemcitabine patient. But that's good. Do you think that you can continue? You've already got 2 patients on.
Well, we only started 6 weeks from here, so we have 3, and the third one is screened now, so it should work. Yeah.
Good. And I know the Schrolls will follow up. I know that's always something we do.
Yes, well, I met with Philippe a couple of weeks ago.
Yeah. Very good. Geraldine, how about in France?
So what I've learned, inclusion criteria, and to know that we can have, patient could have previous treatment, so I didn't know.
Yeah.
And what, can we enroll? I think so, yes.
Yes, exactly. I think the neoadjuvant washout period where you had capecitabine with radiation allows patients to potentially be eligible, I think is a big advantage. And there is the right patient potentially for FOLFIRINOX and paclitaxel, or nab-paclitaxel plus gemcitabine and gemcitabine alone. Yeah, it's just one of the options. Let's thank God that we've got options for pancreatic cancer, I'll tell you. I mean, for the longest time, almost 20 years when we started, we had almost nothing. So, yeah, very good. Harvey, tell us, we'll end out with the UK here.
I think for me, it's the sort of debate amongst the different treatments, really. Because in my role, I deal with lots of different clinical trials, not just in cancer, but different cancer groups, but and outside of cancer as well. So for me, it was the debate, really, and interesting to hear what happens in other countries.
Yeah.
3 to 4 patients, it's certainly doable. As I said at the beginning, we've had several patients through, but we just missed the boat on them really because they've come too unwell too quickly. And providing we can catch them in time, then it's certainly achievable. Yeah,
that's the key. Get them into the queue. And Sebastian, other than not every patient is a performance status 1?
No, it's a really interesting drug. Fascinating drug, and again, it's a useful meeting. I've learned a lot about what other people have available. That's been very interesting. Also, it just reinforces, brings out again why it's important that a trial like this completes. Really, that's what's
if you're a clinical trial list, which I think all of us are, you're here for a reason. You decided to do the trial. You're trying to contribute to the advancement of clinical research. And as I said earlier, this is one of the options. You only got one shot at it, probably for the next 5 or 6 months, and then we're all hoping that the end result will be positive and it'll be one of the armamentariums. It'll be a quandary though, because let's say it comes in. Let's just theorize that it comes in somewhere in between FOLFIRINOX and nab-paclitaxel plus gemcitabine or similar. Then what will be the randomization arm for the phase 3 trial? Doublet will be a standard of care. I don't know if we're ready to say FOLFIRINOX is a standard of care yet, but there will be a doublet, and which one's going to be interesting to see how it plays out. And you have 0, so we only can do 300%, 3,000%.
We haven't been open long. We screened it for you.
No, but we appreciate you.
We'll recruit.
I appreciate your enthusiasm and good questions. And Dr. Shu, for you, so a little different question, because this is your second one, right?
Yeah.
You were in the audience, now you're on the podium. So what we usually do is we allow...
You're running the meeting.
Yeah, you're running. We usually allow the speaker who does the landscape to choose the next one. It's like the Masters. You got to put the green jacket on someone else. Who will it be?
You mean that lady in Paris chose me? That's right. Barcelona.
That's right. I'm voting for Karen. I've already...
I'm going to go for Karen. So, I mean, from my point of view, it's mainly, I think it's just so fascinating, know, this whole, everyone's got different options around the world and all, and I think that's just very valuable as a clinician. You know, I've already done the meeting and I'm comfortable with the entire process, so I'm not really too worried about that at all. I think the only question I had to ask, and I don't know if you're allowed to give us an answer, is can you give us a feel of how many people are locally advanced and how many people are metastatic coming into the trial?
Yeah.
As in 2/3, 1/3?
No, I bet you locally advanced is probably small. Right?
Very small.
Yeah.
The locally advanced are between 10 and 20%.
Right.
Yeah.
Okay. That's interesting.
That's the expectation.
Yeah. That's
the
way it is.
expectation, or that's what you know?
No, I don't have the numbers.
You
It's the
don't.
expectation based on the phase 2 data.
Yeah, so we don't know.
In terms of enrollment, yeah, I mean, I think we've got one, and I'm pretty sure we'll get one in the next. So the only caveat is that it's interesting that you've got Siege. We do think that when Siege opens at UCLH in 3 months, that it will affect.
We wanted to
so
run
we are
this
going
before
to
running
have
Siege.
We're going to have to get our
So Siege will open in 3 months.
No, Siege is open with us.
Well, no, but
we
at
intended
UCLH.
to have it open after this one.
Exactly.
But the paperwork went through for Siege really quickly. So
Yeah, that's right. But you opened it quick, you haven't opened it.
We haven't opened it. That's
So you're going to be in that quandary. You got to throw it into the mix, right?
yeah, we'll have to throw it in. I mean, we still
no,
may
we said
recruit,
we've got to complete.
but we're
We
going
said
to
we'll do it.
complete.
We'll
So
do it, yeah.
that's
That's
fine.
good.
Yeah.
You know, but it is out there, and you know, there's going to be 2 interesting trials, and it then depends on patients saying, what do you want? Just like we were talking about before, what would you do?
Absolutely. Yeah, I think so. You know, this one, like I said, 5 to 6 months. Siege may be a good opportunity. I think that's a good trial too. It would be very interesting to see the differences between how you give the doublet. It's going to be important. Okay, so let me just get some closing remarks from Bruce. Bruce, I'd like you to, have some closing remarks, and then I want to show you a palindrome. How many people know what a palindrome is?
It's same backwards as forwards.
Right. So this is a very interesting palindrome that I think you'll find we're actually going to play it for you, and then Bruce will probably tell you a little bit about the website too and some of the information.
So I promised you at the beginning I'd give you all my card, and so please feel free to reach out to me if there's anything I can do to help or assist in any way.
Thank you.
I want to thank Mark and Nora and Dr. Shu.
Thank you.
And Martin for the great presentations today. Especially want to thank Agnes and Gregory for setting up another fantastic meeting for us. Thank you very much for that. Especially want to thank you guys for giving us a day out of your busy schedules. I know that that's not always easy. It's a commitment. Thank you for sharing with us today. I think we had some great discussion. I think you learn from each other, but we also learn from you too. So I can't thank you enough. So
good. We'll play the palindrome, and then we always take a picture of the group. So we'll have one picture. Gregory, where do you think? Like over here?
Yeah, we thought we'd take it here, so once we're done here, I'll just come up here.
We just got to make sure we turn that thing off, or else you all will go blind. You'll see us like us, all the dots in our eyes.
Can I just say just a few words? This is the website, the study website that we had developed in the U.S. This has been approved by an ethics committee in the U.S. For use from our sites, just to kind of raise awareness on the trial with their patients. It's not approved outside of the U.S., but it is on the World Wide Web. So if you are interested in going on there, you certainly can access it. www.maestrostudy.com. And on this website, you can link to the video that Gregory is now going to play.
And
to add something, excuse me.
Okay.
To add something for those who will attend ASCO, this website will be able. We will be able to reach this website with QR codes. This data codes that will be in each panel, speaking about TS202 and hypoxia at ASCO, and through your iPhone or any smartphone which is working with Androids, you could have access to these 2 videos and the 3rd video which are currently developed on the hypoxia also.
So where do you get
everything will be stocked on the website for the future.
That's good. So how do you get the MOA video? Will that be there as well, or is that a YouTube?
Yes, it will be there.
It will be there as well.
This one that we have seen today, or the one that I'm currently doing.
Oh, it must
because
be a
we
new
have a
one.
new one, which is a 4-minute video, which is currently done.
Okay, that will be new.
So everything will be available soon, and if you attend as ESMO, it will be made also in ESMO. So it's easy because afterwards you could have direct access through your phones.
Yeah. Good. Bruce, anything?
No.
Okay, very good. Let's show it. Or maybe not.
No.
Oh, I think you.
There you go.
The investigational study drug is currently undergoing clinical research and has not been approved for use in the United States, Canada, Europe, or elsewhere. The investigational study drug has not been proved to be safe or effective, and any claims of safety and effectiveness can be made only after regulatory review of the research data and approval of the labeled claims. As someone with inoperable pancreatic cancer, I am helpless. I do not feel that there may be a chance for someone with this disease. I have limited treatment options now, but my doctors, family, and caregivers want to talk about the future. What future? I feel different. With such a diagnosis, it is inevitable that cancer will define me and consume my life. It is hard to believe that there may be possibilities. There may be possibilities. It is hard to believe that cancer will define me and consume my life. With such a diagnosis, it is inevitable that I feel different. What future? My doctors, family, and caregivers want to talk about the future. I have limited treatment options now, but there may be a chance for someone with this disease. I do not feel that I am helpless as someone with inoperable pancreatic cancer. Although the diagnosis of pancreatic cancer that is surgically untreatable can be devastating, it does not have to define one's life. The Maestro study provides eligible individuals with inoperable pancreatic cancer with an opportunity to participate in the clinical study of an investigational drug that may support advancing the treatment of this disease in the future. Specifically, this study evaluates the safety and effectiveness of an investigational study drug when combined with standard of care chemotherapy. The future can be meaningful. There are opportunities today that may change the way this disease is treated in the future. For information about the Maestro study, visit www.maestrostudy.com. Maestro, conducting pancreatic cancer clinical research for the future.
Okay, so you now have seen a palindrome in action, right? We've always heard about it. I'm sure I've seen other ones in my life. I just can't recall. But now we have it. And let's turn off the projector. Oh, while we're doing that, make sure you fill out your evaluation form. It's the orange paper that's sitting in front of you. And make sure you highlight that Bruce did not go through each page of the protocol in there. Exactly, we got that one fixed. And then we're just gonna take a group picture, so as soon as you're done, we'll come up here, we'll turn the lights off, and then you guys are free to enjoy London and the beautiful weather.
Thanks.
Very good, thank you. Okay, very good. Come on up. Don't be shy. Augie, are you taking the picture? It's. I guess the bulb's on, but it's not.
No, I don't work at the Royal Free, but remember our.
This is like having a flash. Come on up. Come on up. Girls in front. Short.
Which is down the road.
Nor are you going to come into?
So Royal Free is in Hampstead.
Come on in.
You were there, yeah.
My former boss was Andy Rose, who passed away from pancreatic cancer.
On the side. Short people in front. You consider yourself short? Short people? No.
You're gonna have to get a little bit cozier.
That's it. I'll stay in the back.
Perfect.
That's it. You have to say that the nice way.
1, 2, 3. Keep smiling. 1, 2, 3.
There's another one.
Another one. Good smiles. Love it. Love it. Perfect.
Were you taking a video or did we show the video again? Thanks everybody. Thank you. Show the video, we run through it, that works out good.
I'll give my best to Maddie.
Yeah, we'll do,
I
yeah.
haven't been in touch with her because I know that you're not changing a life, changing a career plans.
Yeah.
What's going on.